And again, same black box warning along with first gen. But I mentioned earlier, there is an exception. If all else has been exhausted, you have exhausted your reorientation strategies, you have exhausted your de-escalation techniques, nothing has worked, and you talk to the legal representative and the supported decision-making people and the service user, and it's just you're out of options, there is one option you can go for. Particularly, this is for psychosis in the context of behavioral and psychological symptoms of dementia. We have risperidone. So risperidone does have a randomized controlled trial that has tested its use in this vulnerable population. But again, this is like a last resort thing because again, so many risks, cognitive worsening, sedation leading to falls and fractures, the aspiration pneumonia, etc., etc., and of course the black box warning itself. But if it needs be, fine, risperidone, lowest dose is in super low doses, shortest duration, like max 8 weeks. If it's not working by that time, just give up on it, stop it, because it's not going to do anything beyond that. You know, review regularly if you still need to use it. But again, drug of absolute last resort. Now, side effects. So we talked about ham. I won't go into the ham details anymore. Of course, all of these will block ham to differing degrees. So like I said, for example, olanzapine has H1 as a bigger favorite, so it will be very sedating. Risperidone, not as much, so not as sedating. Still sedating, but not as much. So again, to varying degrees. Okay, you have QT prolongation here. So while again, QT prolongation does not automatically mean the person will develop arrhythmias, it's just like what you call a surrogate marker. It's like a substitute. But it's not really indicative if a person will develop the life-threatening torsade de points. But you watch out for it, right? You watch out for it. Among the second-gen antipsychotics, the ones to really watch out for, quetiapine, amisulpride. Quetiapine, amisulpride, those are the ones to really, really watch out for. While nausea and vomiting are listed as side effects for the so-called antipsychotics, you also have to remember that these are dopamine type 2 receptor antagonists. One place you can find these receptors is the chemoreceptor trigger zone, as in the place with all the nausea and vomiting thing. So you block that, you would expect, well, less. On top of that, some of these drugs are also 5-HT3 receptor antagonists. So there's actually more than one mechanism for antiemesis for many of these drugs. So much so that drugs like olanzapine, if you look at the figure here, are actually considered as part of a regimen for chemotherapy-induced nausea and vomiting prophylaxis, CINV, prophylaxis. It's not just olanzapine, actually. A parenteral form of amisulpride was recently approved for this purpose as well, and chlorpromazine may be used as an alternative agent. So, in terms of nausea and vomiting, yeah, it can still happen, but if you compare it to something like an SSRI, you'd expect SSRIs to be the more nausea and vomiting kind of drugs. One particular side effect that's notable for second generation, so not third, this is a lower risk for third, but for second generation so-called antipsychotics is metabolic syndrome. So metabolic side effects, insulin resistance, increase in BMI and waist circumference, dyslipidemia, hyperglycemia, and all of that. Okay, they can occur to varying degrees for the second generation antipsychotics. So please don't make a blanket statement for this. I'll give you a memory aid just very shortly. But on this note, this is one reason why I really dislike when certain teaching materials or when it is commonly taught that because of the EPS with the first generation so-called antipsychotics, prolactin elevation, this is why second generation antipsychotics are first line. That is not true. The actual accurate answer is really it depends, because when you look at the efficacy of antipsychotics in first episode psychosis, across all generations, generally the same. If it's like for refractory schizophrenia, clozapine is kind of like, yeah, it's the outlier up there. But for like first episode psychosis, they're generally, so far we've seen there are no differences in their efficacy. So what are the criteria for choosing antipsychotic? That would be, of course, side effects, the person's own medication history, medical history, family history. I mean, there are some people who would actually even prefer dystonia over diabetes, or perhaps they have a comorbidity that just cannot let them develop dyslipidemia, right? And from a clinical standpoint, it's just EPS seems preferable from a safety perspective. So really depends. It's a more difficult answer, really, but there is no first line here. So you really have to do it on a case to case basis. Plus, again, the different second generation antipsychotics will cause these metabolic side effects to varying degrees. Why do these happen? We don't actually have a definitive answer. There are certain theories. One of them is when you block the H1 receptor and the 5-HT2C receptor at the same time. So H1 receptor, weight gain, 5-HT2C receptor, appetite. So that combination, that's not very good at all. The other hypothesis I've seen is M3 receptors that are bound to by antipsychotics may play a role in insulin resistance, the ones in the pancreas, right? And the other is, well, a receptor X that we haven't really identified yet, leading to all of this. Oddly convenient, but anyway, we don't really know why. Another issue, again, that might make you reconsider second generations as immediately first line is this stock photo I have blocked from behind. COVID is still in the air as of recording. And the thing with COVID is we have seen with observational studies that certain risk factors confer a higher risk of COVID mortality for these patients who have COVID. One of those being cardiovascular diseases. Things like, again, metabolic dysregulation that can be risk factors for worse COVID outcomes. That means this particular side effect is a bigger cause for concern while COVID is in the air. So it's really something you really gotta watch out for. So this is from Pillinger et al. Just one version to show the quantitative risks for the metabolic side effects. As you see, it's not a uniform thing. Some antipsychotics have it worse than others, and you'll see the numbers here for the different parameters like weight, blood sugar, and so on. They're all listed here, and you'll see it's not really very uniform across the board. And to help you remember which antipsychotics you really gotta watch out for, which have a higher risk, which have relatively lower risk, we have a handy mnemonic, just using those we have in the Philippines only. So, haha, Munchlax type 2 diabetes. But in all seriousness, if you line up the letters in descending order of high to moderate to lower risk of metabolic syndrome among the second generation and third generation antipsychotics, you will end up with CoQ10. Starting with CO, that would be clozapine, olanzapine. These two have the highest risk for metabolic side effects among all the second and third generation antipsychotics. So clozapine, olanzapine. If you see those, really gotta watch out. So after Co, now you have Q10, coenzyme Q10. Then you have the Q being quetiapine. Where does the 10 here? The 10, draw the 1 as usual, but then the 0, draw it like a superscript. So it looks like it makes the 1 look like a P. So the standing part of the P. So it becomes QP. P there is for paliperidone. And, paliperidone is pretty much adjacent to risperidone. So quetiapine, paliperidone, risperidone. While quetiapine may have significantly more effects in elevating triglycerides, cholesterol, etc., generally it's considered moderate risk together with paliperidone, risperidone. Now, where are the rest? Well, there is no letter A in the mnemonic, so that's where all the rest go. Aripiprazole, amisulpride, I'm not so certain because, it's a European drug, so it's not usually included in many of the comparative analyses, meta-analyses, and so on. But anyway, we'll just put it there in the end. But what we're sure is aripiprazole generally has the lowest risk. So since letter A is not in the mnemonic, but it doesn't mean you should be letting your guard down, because there have been reports of people on aripiprazole who have gained a lot of weight and who have seen their metabolic labs shoot through the roof. So, don't let your guard down. I mean, lower risk, but still don't let your guard down. All right. So again, CoQ10. Forest plot here is again to demonstrate that there's a side effect profile. These drugs aren't really uniform. Like, for example, you look at prolactin elevation. It is only if the drug's confidence interval, the entire thing, is beyond 0, then you consider if it's more the drug side effect, and then, it's placebo is better, or if it is more a placebo thing and the drug is better in that regard. Okay? If you look here, there's prolactin elevation. Again, so other second gen, third gen, they pretty much overlap with 0, so no different than placebo. But if you look at the profiles of, say, amisulpride, risperidone, paliperidone, these have gone beyond 0, such that placebo is better in that sense, right? They are different from their peers. There is really a lot of prolactin elevation with risperidone, paliperidone, amisulpride, along with EPS. So again, really got to study them as individual drugs. Okay, I think the only one you can study as a pair, risperidone, paliperidone, there's just like 2 differences. One is just 5 times as expensive, but less liver, liver metabolism. So that's the only thing you can study as a pair. The rest, treat them as individuals. Okay. Now, what else? I mentioned already, right? Differences EPS and prolactin. Again, lower, but not absent. And especially for risperidone, paliperidone, amisulpride, do not count those out. The metabolic stuff, venous the rest of these are kind of rare, so this is something you can discuss in ClinPhar. Seizures, highest risk among the second, third gen would be clozapine, but clozapine has been safely used in people with epilepsy, so it's really mainly chlorpromazine with the biggest issue there, right? So, yeah. Of course, preemptively, you would want to have preventive lifestyle interventions in place, but take note, it's not as simple as telling someone to exercise. In fact, I would advise you against simply telling someone to just exercise. Remember, these drugs are on top of the schizophrenia baseline risk for metabolic side effects, you also have these drugs are sedating. It's very difficult to get your butt off the chair if you're feeling just sedated the entire day, for instance, right? So there's just many factors come into play. So you may want to, some people may just want to opt for a prescription medication, and those have been tested. So one thing that we can recommend to everyone that not everyone does apparently is monitoring FBG, HbA1c, fasting lipid profile. Because outpatient, in the Philippines, I've talked to practicing clinicians, we rarely monitor if it's outpatient. So that's one thing I really routinely counsel people on. They're not aware that you probably should be monitoring your blood sugar and cholesterol a lot when you're on the second gen. Third gen, not as much. To be safe, sure, but the concern is more pressing if it's like second gen.